Good evening.
Very good. Very good evening to one and all present with us. I am Arpita from Clarinet, and Clarinet is very proud to be associated with the Indian College of Anesthesiologists, ICA, as a digital partner for this program. The topic for today is attitude, ethics in healthcare. Clarinet would request all doctors to join India's fastest growing community of doctors, which is free and exclusive for all doctors. So now, without doing any further delay, I would like to start with the session by handovering the same to Dr. Jayashree Sood ma'am, who doesn't need any introduction, but yes, she is the CEO of the ICA. So ma'am, over to you.
Thank you, Arpita, for those kind words. And good evening, everybody. Welcome you all to the 99th webinar today. And it's a very special day, of course, because we're going to have a very important webinar along with very eminent moderator as well as the speakers. So before I just talk about the webinar today, I would like to again reiterate, as you have seen, all of you, about the 100th webinar, which we are going to celebrate next Wednesday at 7 o'clock. And you saw the whole program on the screen, which showed that it's going to be a very, very interesting program, not only for the students, but also for the faculty. And here we'll be having 3 virtual halls as she projected with all the new modalities of the simulator training. For today, it's a very important webinar. It's a very special topic, attitude, ethics in healthcare. The attitude, ethics and communication, the AETCOM competencies for anesthesiologists. We know that ethics has become so important. Everything without ethics, there's nothing. And it forms a very important part of the healthcare and of course in our fraternity as well. So today for this, we have a very eminent moderator, Dr. Babita Ghai, who needs no introduction. She is a very, very important member of the Indian College of Anesthesiologists, and she is the professor, which we all know, at the PGI Chandigarh, the Department of Anesthesia. She has a whole lot of honors, international positions. She's been holding the IASP Presidential Task Force, and she's got national positions of being the specialist board in the DNB. She has many awards to her credit. Last year itself, she got the Presidential Award for Academic Excellence by the ICA. She's had many grants, national and international, and more than 150 index publications. So a very elaborate CV. I'm not surprised, we are not surprised, because she's so dynamic and she works so hard. So thank you very much, Babita, and I just pass on the proceedings of the webinar to you.
Thank you, ma'am. Thank you for your kind words. First of all, I would like to welcome all the delegates to this 99th webinar of ICA, which have been so vibrant in conducting the webinars for nearly 2 years. And we are now welcoming you to the part 2 of AETCOM competency, that is attitude, ethics, and communication skill. Some time back, we had discussed about the part 1, that is communication skills. Can I request Dr. Murali to share his screen, please? And during that webinar, we talked about communication amongst ourselves and communication with the patient, which is now we would be talking. This AETCOM competency has become the essential part as far as the undergrad and the postgrad curriculum of the medicine goes, as per the NMC rules and regulation. And after talking about the part 1 of communication skills, we'll be moving to the second part, which is also essential and extremely important, that is attitude and ethics. So first, I'll call upon Dr. Murali Thondebhavi, who is a senior consultant at Anesthesia and Pain Management. He at Apollo Hospital, Bangalore. He also holds the position of Distinguished Clinical Tutor at Apollo Hospital Education and Research Foundation. He has been a bright learner right from beginning. and he holds 3 university gold medal during the MBBS. He has nearly 13 international publications to his credit. He's been invited speaker to various national and international scientific meetings. He is a dear friend, and he has authored a book, Think Like an Anesthesiologist. He has a special passion about photography, and we see really during his WhatsApp communication wonderful photographies which is clicked. So he'll be talking on an extremely important topic, that is attitude in healthcare workers with special focus to anesthesiologists. Over to you, Dr. Murali.
Thank you, Dr. Babita. Thanks for the kind introduction. Good evening, ladies and gentlemen. At the outset, I would like to thank the Indian College of Anesthetists for inviting me to speak in the 99th webinar, which is actually a commendable achievement, and congratulations to that. And we're looking forward to the 100th webinar coming up. Now, the topic that was given to me for this evening is attitude in healthcare, with a focus on the anesthetist and what we do. Now, I thought I'll start with this slide. You can see, 3 laborers carrying bricks. And if they were asked a question, what they were doing, and they gave 3 different answers, that would be the end of the talk. Because in those 3 answers, we would know what attitude is. But we would like to spend probably another 20 minutes understanding a little bit more about what attitude is. So the outline of my talk will take you through as to what is attitude. Now, it's very difficult for us who are giving anesthesia on a day-to-day basis to read about attitude, which is a purely in the domain of psychology. And we'll see what is the importance of attitude. And then we'll focus on the anesthetist as to what attitude means to an anesthetist and what are the important aspects of that. And finally, a few slides on why all of us should embark on having positive attitude. Now, when we see an iceberg, now we all know of this common phrase and the famous phrase of tip of the iceberg. Now you can see here a very nice photo clicked with the iceberg on the top and bottom both seen, and we cannot see the bottom of the iceberg. It's quite big. If we look at a person, what we see is the knowledge and skills, and to an extent the behavior of the person. But what is unknown to all of us when we see another person is the attitude. And as we all know, the attitude forms the bigger part of this iceberg of a person. So attitude by definition is a hypothetical construct which represents an individual's degree of like or dislike for an object. And when we talk about an object, we talk about an object as in a person, a place, a thing, or an event. So an object, when we talk about an attitude, is not just an object in the real sense, but it could be a person, thing, a place, or an event. So to give you an example, this is the team led by Virat Kohli last year when RCB were playing, and I have a positive attitude because I am from Bangalore. I love this gentleman because he has done so many great things and is an inspiration for many of the youngsters in this country, and I have a positive attitude about this person. Now, of course, who would not feel proud and feel positive about August 15th, 1947? It's a proud moment, and all Indians feel a positive attitude towards this. And similarly, this is one of my favorite breakfast dishes, and I have a positive attitude towards a nice crispy masala dosa. So you can see here, I have a positive attitude towards events, person, thing, or a place. Now, coming to negative attitude, I'm sure many of you would agree that, we would like our roads clean, our places clean in India, and we have a negative attitude towards people like this, or even towards violence. So this is a screenshot of the movie which came out highlighting the riots in Bombay. None of us want this. So we have a negative attitude towards it. So this is to give you an example of what attitude is when we talk about, the object of attitude. So positive attitude generally results in desirable outcomes for individuals or organizations, and a negative attitude results in undesirable outcomes. So this is a brief overview of what attitude is all about when we talk about positive or negative attitude. Now, the components of attitude are important. Now, there are mainly 3 components, which are cognitive, affective, affective more in terms of emotional, and behavioral. So to give you an example, when we talk about affective attitude, it is the feelings or emotions that are attached with the attitude objects. So to give you an example, spiders. Many of colleagues that I know don't like spiders. That's why I didn't put a photo of a spider here, because I love photographing spiders. Many of you might not have a good attitude towards spider because of your affective component. Now, this can be altered. Now, how can we alter this? Now, there are various studies. Now, this one, which was done in 1992, looked at subliminal positive images and subliminal negative images. Now, we are exposed to this every day. Now, when you read a newspaper, you are subjected to the negative images. When you listen to negative news on social media, you are subjected to subliminal negative images. Now, what it does is, if you can see here, the positive images that we're exposed to improves our attitude, improves our personality, and also improves our attractiveness. Whereas if you are subjected to negative images on a daily basis, it affects the attitude, personality, and attractiveness. This is working at an affective component level. The same thing can be applied when we are exposing ourselves to this component which we did not like, the attitude object. So when we are increasing our frequency of exposure to something that we do not like, but we need to develop a good habit towards it, we actually improve our attitude towards it. So the affective component can be tweaked by priming ourselves to positive images, and also by subjecting ourselves to increased frequency of exposure. Now, when we talk about the cognitive component, it is something which we are based on beliefs, thoughts, and attributes, and also on all the calculations that we do. So an example for this is, I would like to buy a new car. Now I look at a lot of aspects of it: safety, price, resale value, and then I develop a liking towards the car. So this is how we develop the cognitive component. Now, this is what happens to most of us as anesthetists. We develop certain cognitive component to certain things. Like example, it could be a type of regional anesthetic block that you're doing, or it could be a type you handle the airway. So you develop a cognitive component of liking or positive thoughts towards that object through the cognitive component. Now, coming to behavior. Now, past behaviors with the attitude object can affect this, such as, say, example, you have signed a petition against a nuclear plant, and the next time you hear about a nuclear plant, you think it's negative. So this is based on past behaviors. And this is more important if the attitude is weak or ambiguous. So if you're not sure what you need to kind of respond to that, your past behavior will dictate how you behave towards it. And in this part of the component, the body language plays a very important role. So now, when we look at a component structure, the attitude structure, we can think of it in a one-dimensional view, wherein you can either have a high negativity, that is, you don't like it at all, or you can have a high positivity, that you like it quite a lot. So if you look at a two-dimensional view, I'm sorry, but somebody is not muted. Can I request them to be on mute, please?
Yes, I'm muting everyone. Please continue.
Thank you. So if you take a two-dimensional view, you can have a little bit of positivity, a little bit of negativity. So you can have an ambivalent kind of a view to a component or attitude. So this is how you can have. So you can have a completely negative attitude towards this object, like I told you about the violence, or you can have a high positive attitude about something, say an example like your family. So you have a high positive attitude, and certain things you can have dual attitudes where there is ambivalence. Now, why do we hold attitudes? Now, it's very important because this is something which is quite deep, which we don't understand. One is the object appraisal. That is, we need to understand the objects that we deal with on a daily basis. When I say object, I'm not talking about one object. As I told you, it's a person, a place, an event, or an object. So we need to understand how we deal with it so that we can have shortcuts to dealings, or we, where we can kind of decrease the amount of brain power that we are using. The second reason why we need to do it is we need to adjust socially to where we live. So that's a tribal mentality. We need to identify with the people we like, so we tend to do things which they like. And third, most importantly, is something which is to defend the self from internal conflict. So we have something inside which is telling us to do, and to defend the self, we externalize this. So we hold attitudes to defend the self from internal conflict. So the last place we want to have a conflict is within ourselves. So this is another reason why we hold attitudes. Now, coming to slowly kind of moving to anesthesia. Now, I would like to start off by asking a question. What is the purpose of education? Why are we all educated? What are we doing here? Now, it all boils down to the common theory that is in all education circles, that we have a pyramid which is based on knowledge, skills, and attitude. Now we start off our schooling, we're learning, ABCD, 1, 2, 3s, and slowly climb the ladder, doing our masters or PhDs. And what we are doing here is we are being competitive. Whenever we are acquiring knowledge, we are being competitive, and we're in a mode where we look down on others. We want to be on top. We try to be competitive, as all of us have been. All of us listening to this talk are probably, in the top 5th percentile of their class throughout their career. Next, what happens in our career is we go on to acquiring skills. And when we acquire skills, there's a change in our mentality. We have to be humble because we need a master. So when you start your postgraduate training, there is a master. It's your professor, your assistant professor, your lecturer, and there needs to be an element of humility. We are humble now because we need to learn the skills, and none of the books can teach us these skills. How many of our YouTube videos we watch, we can't learn these skills. So we start becoming humble. Now, after this is when the attitude starts to build. Attitude in the sense, the attitude towards education and making us a complete person. Now, here is where it matters. So attitude can be taken in all these different formats, which is self-motivation, self-confidence, an amount of integrity, being optimistic, enthusiastic, cooperating with others, having a high level of tolerance, which I feel is one of the most important aspects of having a good attitude in learning and later leading, and finally, a professional conduct. So attitude now starts becoming an inner narrative, a narrative which we tell every day to ourselves when we wake up, and this overtakes everything else. So what happens here is the attitude with the motives, the ethics, which we're going to listen in the next lecture, the beliefs that we have, the values that we have been brought up with, the standards that we adhere to, and finally our judgments impact our behavior, which is seen by others. So here we are actually changing what is submerged inside the iceberg to what is seen by people outside. And what can happen when attitude and energy are not focused well is what we see in this grid. So if you see a person with a low attitude, a low positive attitude, or I would say hope here, and a low energy is depressed. And at the other end of the spectrum is a person with high positive attitude and high energy. He is manic, okay? And in between is where we all need to be, where we are most effective. If we have a low attitude and high energy, we end up being bitter, we end up being angry. Whereas if we are having high attitude and low energy, we end up just sitting, dreaming, not doing enough. So this is an important slide, which I would like to stress, especially for the juniors out there, that you need to be in your mid-range where you have your energy and attitude equally balanced. Now, can we measure attitude? Now, psychologists have been measuring attitudes, and we have studies which have been using this. So one is an explicit way, and there is something called as Likert scales, which is used where the questions are asked in terms of whether we strongly disagree or strongly agree. And you might have answered a few questionnaires which come through various channels on this. And another one is semantic differential scales, where we are asked to kind of talk about something as being bad or good, negative or positive, or we dislike or like. So these are explicit ways where we can measure attitude. And I will not go into the implicit ways, which are evaluative priming and implicit association test. So when we look at this education, and finally what we are, is probably 85% of our attitude and 15% of the skills and knowledge. Now, knowledge and skills are kind of a part of the education, but attitude is something that we have to develop. Now, what about attitude in anesthesiology? Now, here I was looking at what's the evidence and what's been happening with regards to attitude in anesthesiology. And we'll look at a few papers. Now, I don't know whether I can see the top here. That should be okay. So when we look at the papers on attitude, let's start with our relationship with the patient, which is of utmost importance when we kind of talk about a doctor-patient relationship. And what they found in this study was that an empathetic attitude at the pre-op visit and equally spending time with the patient had a big effect on the patient anxiety and satisfaction. Now, this was a good study which was done in 2003 in Scotland, and 222 anesthetists answered this, and the range of the seniority varied from a trainee to the senior most anesthetist. And they looked at the attitudes of these anesthetists towards leadership, communication, teamwork, stress and fatigue, work values, and human error. So I'll take you through what actually came out of this study and what's important on a daily basis. So when it comes to leadership structure, the inference we had was that the seniors should be open to suggestions and juniors can assume leadership in the interest of the patient if things were going wrong. Now, this is very important because being in the presence of a senior or being in the presence of an authority sometimes can lead to people not opening themselves up when things are going wrong. So the survey which was done here showed that the attitude of anesthetists was strongly favoring that seniors should be open to suggestions and juniors should assume the leadership in the interest of the patient. Coming to confidence and assertion, the inference was that we should seek help when required, and we should have an open communication channel at all times to people in the operating theater. So we should be open to communication. People should be able to talk to us. Now, coming to information sharing. Now, this was in 2003, mind you. So they did not have the WHO checklist then. So they said, you should verbalize the plan to all members of the team in the OT. So now we have the WHO checklist and we verbalize all our plans. And it's very important to close the communication loop. That is, when we have told something, we have to ensure that the other person acknowledges what he has heard and understands it quite well. Now, coming to stress and fatigue, which is again a very hot topic, especially in the Western world following the COVID crisis. It's very important. I'm sure all of you working in big departments will agree with me that we should not try to bring personal problems to work because it affects others. So the survey came out with the inference that we should not, as much as possible, bring personal problems to work. And we should be sensitive to personal problems of colleagues. So we should not be bringing personal problems, but at the same time, we should be sensitive to others so that we are able to pick up if somebody is in trouble. Now, coming to teamwork, which is again very important. We should be open to feedback from others. We should disagree with others in the patient's best interest. So if there is something going wrong, whether it's an orthopedic surgeon, whether it's a gynecologist or a nurse doing a mistake, we should disagree with them and we should kind of be open, especially with regards to patient's best interest. And among team members, the inference from this study was that we should resolve conflicts early because having conflicts and working together doesn't go well. And we should make an effort to understand the personality of other team members whom we are working with. Now, coming to error and procedural compliance, the attitude that we should be having is that human error is inevitable, but we should be learning from it because error is not a sign of incompetence. All of us do mistakes. We should be able to openly accept it and learn from it and teach others from what has gone wrong. Now, work values. Now, the attitude of an anesthetist, I'm sure all of you will agree that you like to work with a person who is good. So try to be a person that others enjoy working with. And what the anesthetists in the survey felt was that a good reputation was important to them. So a good reputation is important, and they valued the goodwill and compliments of other fellow workers. Coming to organizational climate, the department leadership, they felt, should listen to all the staff, and adequate training should be given to all the team members when they have been assigned roles. Now, this was what this paper came out in 2003, and I couldn't find anything recent which was as detailed as this. But looking at where we have actually moved into is the non-technical skills, or the ANTS as it's popularly called. Now, ANTS is something which was developed by, again, the Scottish team from Aberdeen. And what they're looking at is how anesthetists, apart from their technical skills, manage their entire operating room. So they are looking at how task management is managed, how they work as a team, how they are aware of the situation when things are kind of going not too well, and finally decision making. So a few examples here were that the behavior markers of good practice was that the anesthetist confirms the roles and responsibilities, discusses the case with surgeons and colleagues, considers requirements of others before acting, and cooperate with others to achieve goals. So this is something which they said is a very good thing, very good practice, and something as an attitude that you can develop over a period of time. Now, coming to the negative or the poor practice is, again, they had a few behavioral markers. And if you go through this paper, it's a very nice paper to kind of implement, especially in your training. Now, what does an excellent anesthetist do, which a good anesthetist doesn't do? Now, this was a very nice study which came out from Sweden. And they interviewed nurse anesthetists or technicians who are working with anesthetists and said, what are the main things that these excellent anesthetists are doing? So they told that the excellent anesthetist is structured, is responsible, and has a focused way of approaching work tasks. They're clear and informative, briefing the team about the action plan before induction. The main thing was, they said they're humble to the complexity of anesthesia, admitting own fallibility. And they're always patient-centered, having a personal contact with the patient before induction. And they're fluent in their practical work without losing an overview. And finally, they said they're calm and clear in critical situations, being able to change to a strong leading style. So this is something which I want to highlight to all the juniors who are listening to this talk, that they can develop these personal traits or the attitude and improve themselves as they progress in their career. And looking at attitudes towards basic sciences, none of us like basic sciences, physiology, anatomy. We don't want to. We want to be doing all clinical work, the latest stuff. But if you look at how the attitudes of residents and consultants change, you can see that this study showed that the attending anesthesiologists' scores were significantly higher than resident scores in the importance that they gave to basic sciences. So as you progress in career, you start realizing that the basic sciences and the fundamentals are more important than the later things that we learn. So coming to, we saw what all attitudes that an anesthetist can have, especially in the theater. I wanted to touch a little bit upon developing positive attitude. Now, this is extremely important because it's not only helpful for professional life, but also for personal life. So when I was writing my book, Think Like an Anesthetist, last year, the reviewers who read the book initially came back and told me that you should be writing a chapter on how to be positive and happy, because we are seeing a lot of people unhappy with their lives. And I started off my chapter saying that, you might wonder why I include this chapter on happiness and positivity in anesthesia related book. But would you want to be treated by an anesthetist who is not positive in his outlook and is unhappy? I presume not. You wouldn't want to be flying in an aeroplane where the pilot is probably thinking that he's going to crash, isn't it? So this chapter actually highlighted how you should be positive and happy. And what I learned through that is what I'm going to share in the next few slides. Now, this is a paper which I would request, if people are interested in reading more, to read. It's a seminal paper on positive emotions and how to develop positive attitude. Now, what this author said is that you need to have a subset of positive emotion. And the subset includes joy, because joy sparks the urge to play. You need to play. Interest is another subset of positive emotion, is a part of the subset, and it sparks the urge to explore. Contentment is another important aspect which sparks the urge to savor and integrate. And finally, love. Now, love sparks a cycle of all the above: joy, interest, and contentment with a close relationship. It could be your family member, or it could be a friend, or it could be a colleague. So positive attitude has side effects. So I labeled this as positive attitude has side effects because there are plenty of movies which are made for, side effects. So here, if you look at positive attitude, now it broadens people's attention and thinking. It undoes the lingering negative emotional arousal. It builds psychological resilience. It builds consequential personal resources. So you end up having more personal resources at your disposal, which might be useful later in life. It triggers an upward spiral towards a greater well-being in the future. And finally, it seeds human flourishing. So as a community, we'll all flourish if all of us start having a positive attitude. And building a positive attitude is not that difficult. You build a circle of positive people around you. You learn to play. Now, play in the sense of games, it could be indoor games, outdoor games, or any kind of other games. Learn to play because you'll enjoy. Write about the positive experiences that you have, especially writing a line about what you're grateful for in that particular day will go a long way. Meditation. Now there are umpteen number of articles which are written and about meditation and positive attitude, and you can check it up on the net. And one of the most important things that most of them highlight is you have to look after yourself, physically, mentally, and spiritually. And finally, it's important to get pleasure out of simple things. And I'm sure all of us have understood the importance of these points in the last 2 years, which have been difficult times for most of us. So the choice is yours. With a bad attitude, you can never have a positive day. And with a positive attitude, you can never have a bad day. And here I would like to highlight what happens in every cell of our body. What is happening here is there are microtubules, there are cell organelles which are working to their highest efficiency, communicating with each other to the highest efficiency, and still not having a negative attitude, because if they had one, we would not be alive. So coming to the story that I started with, the three people carrying the bricks were asked a question what they were doing. Now, the first one said, "Can't you see I'm carrying bricks?" The second one said, "I'm earning my living." But the most important answer of all came from the third, who said, "I'm helping build a temple where thousands will find peace." So I will leave you with this story to contemplate on what attitude is in your life. Thank you.
Thank you, Dr. Murali, for such an comprehensively covering a complex topic and so beautifully covering it and emphasizing the role of positive attitude. And the mantra taken is never sleep on any conflict. Resolve the conflicts as early as possible. It's so important to have your positive attitude. Thank you very much. So we'll be having all the question and answers towards the end after the second speaker. So having heard about from Dr. Murali and our renowned speaker, now we will move on to our second eminent speaker and a very important and essential topic of the day, that is ethics of our healthcare worker. So the next
Babita, we can't hear you. Is it Babita's network?
I think, ma'am, this is a network issue. Hello,
Okay.
Babita, ma'am.
So I can introduce Dr. Nagpal. Babita, I'll introduce Dr.
Jayashree, ma'am, please go ahead. Please switch on your video.
Okay, just send it again.
Yes, ma'am, we can see you.
Okay. I think there's some network problem with Babita, but that's no problem. So I'd like to introduce Dr. Neeraj Nagpal, who is a consultant physician and a GI endoscopist. He's at Chandigarh. He is the Managing Trustee Medico Legal Group and the ex-president of the IMA Chandigarh. He is the director of Hope Gastrointestinal Diagnostic Clinic at Chandigarh. And he also is he's also a member of the various societies. He's a fellow of the International Medical Sciences Academy and the Indian Society of Gastroenterology. He's also an affiliate of the Institute of Medicine and Law. He's a member of editorial board of several committees, and he has edited several books, especially on medical legal aspects of various subjects, dermatology and plastic surgery. He has had multiple, it's an elaborate CV and really very, very impressive. Thank you so much, Dr. Neeraj, for having taken out time for our webinar. And it's a very important topic on ethics. We would love to hear you. Thank you very much.
Thank you so much, ma'am. I must thank Indian College of Anesthesiologists, but I'm upset with Dr. Babita for having put me after such a masterly talk, because now I'm jittery. What would be my effort worth? So when we talk of ethics in medicine, we always talk of Hippocratic Oath, which was starting point for ethics in medicine. But my question is Hippocratic Oath the only document on ethics? Is there no ethics in politics? There was Manu's code of Manusmriti, Kautilya's, Gautam Buddha's Dharmapada, Akbar had also printed his own. And this medical ethics has been changing with time. The Hippocratic Oath of 5th century BC changed in 1948. Again, a Declaration of Geneva came, Universal Declaration of Human Rights came. And now, latest, the National Medical Commission has placed in public domain the NMC RMP Professional Conduct Regulations 2022, on which we are supposed to give our inputs, which will be what the law will be for doctors as regards ethics and professional conduct is in future. The original Hippocratic Oath, if we discuss, the main issues, the main principles were that you should benefit, you should not do any harm, and you should respect your teachers. There was prohibition against abortion, euthanasia, and sex with patients. This was the crux of the Hippocratic Oath. The problem or the issues which are arising today are in regards to patient autonomy and social justice, which means equitable distribution of health resources. All this was not part of the original Hippocratic Oath, and this was not what was initially intended. Most universities, even in states this study was conducted, they swear to some kind of a variation of the Hippocratic Oath, but only 14% of these oaths prohibit euthanasia, 11% refer to a deity, 8% forbid abortion, and 3% prohibit sexual relations with patients. 50% of them do not refer accountability at all. When we look at doctors and their working today, what we are faced with, we are finding increased government regulation, increasing cost of medical technology, third-party payment systems, aggression and violence, unsympathetic law and order machinery, half-baked medical knowledge, myths and misconceptions, and demand for patient autonomy and documentation in a population which is largely illiterate. This is the condition we have in India. And a doctor today in India is an entrepreneur, and he has to fulfill the ethical responsibilities towards his patients, family members, employees, bankers, nation, society. He's also an employer, a counselor, manager, and taxpayer. And his ethics are not restricted only towards the patient. We are having today to fight disease, costs, ignorance, insurers, government, courts, patients, and the press. Where earlier, the doctor used to be treating or the patient, and he used to be fighting the disease. So basically, doctor and patient used to fight the disease. Today, the doctor is having to face so many adversaries, and this is where the issues are arising. And in India, obviously, this kind of scenario is very much existent. And when we talk of ethics in this kind of a scenario, it is an oxymoron, to say the least. Let us go into the depth of what is happening. Supreme Court orders one thing, state governments do something else. Are MBBS doctors or doctors of modern scientific medicine the only ones who can practice modern medicine? Some states say no, that can be practiced by people from other systems of medicine. Why I'm bringing these points up is because ultimately they affect us in our professional practice, and the bulk of the effect is faced by the ethics that we work with. If I am asked, what is your definition of ethics? My definition is that it is a way of life and the way we conduct ourselves, which we imbibe during our professional training by observing and working with our teachers. And in my view, ethics is related more to morality than to law. But unfortunately, in India, we are seeing a lot of conflict between medical ethics and law. If you ask me today in PGI itself, in an emergency, there would be at least 20 patients who would be on AMBU bags. And the situation is such that under Consumer Protection Act, if a patient dies, unfortunately, the compensation which is awarded on the basis of the person's income. So am I to provide health resources predominantly to the people who are rich, so that I am not forced to pay compensations in crores? Because if a poor patient dies by my not giving him a ventilator, the compensation asked for may be a few lakhs. But if the rich person dies, the compensation which I may have to pay may be in crores. So do you not think there is going to be a bias in my mind when I am to decide that the only ventilator which becomes available, I will give to the person which is most high risk in my view for problems to be created for me? Now, this is a classical scenario where there is a conflict between medical ethics and law. We were never taught this, that we have to differentiate between patients based on their socioeconomic status. Is it ethical for a doctor to drive past an accident victim on a roadside? But do we not see this thing on a daily basis? I will not name the person. Senior head of department, again from PGI, faced a problem for 3 years because she assisted somebody on the roadside while going from her residence in sector 24 or I think 11, it was, to PGI. And the case was filed against her, and she had to, it took 3 years finally for her to get out of the whole thing. And from her mouth, these were her words, I will never ever try to help somebody on the roadside in case of an accident again. Again, a classical example of a conflict between my medical ethics or a doctor's medical ethics and the law. For a doctor to accede to a relative's request to let a patient die by switching off ventilator or decreasing vasoactive support. Passive euthanasia has been defined as Common Cause of India versus Union of India, Common Cause Society versus Union of India 2018. They have given particular guidelines on how a passive euthanasia is to be conducted. It was also brought up in Aruna Shanbag's case, but to a limited extent. But Common Cause Society judgment has finally laid down the guidelines. But to my knowledge, there is not a single patient in the country, I stand to be corrected, you are all anesthetists, you will be dealing with this problem day in, day out, where the procedure which has been laid down by the Honorable Supreme Court has been followed to the T in any single case. Whereas we are acceding to relatives' requests to switch off the ventilator, and all of these are not being declared brain dead under TOHA. Because for passive euthanasia, there is a particular procedure which has been laid down now by the Supreme Court. We are not following that, but the problem exists. And again, it is bringing medical law, medical ethics and law into confrontation. For a doctor to do CPR on demand in a patient where chances of survival are nil. So many times I'm asked this question, doctor, this patient is occupying a bed for the past 2 years. We have had umpteen times that the patient has arrested. We have revived the patient, but the bed is occupied, resources are occupied, and they are denied to somebody else in need. Again, a issue where medical ethics are questioned on a daily basis in major institutions. For a doctor to use surrogate mother to deliver child of Karan Johar, I think our ethics and law were in conflict here. For a doctor to desire that the patient he is resuscitating dies and does not go into a vegetative state. Very provocative statement. But look at this judgment from, this is Andhra High Court. Mr. Sanjay Bhutha versus Dr. Jayashree Desai. During surgery, there was a cardiac arrest and the doctors revived the patient. The patient was in vegetative state. Now, what the court says, routine, had Srimati Rupa Mutha died during the procedure, it would not have given such trauma to her husband and daughter, hence imprisonment. I can only read between the lines here, and what I understand is the Honorable High Court judge is saying that it may have been better to let the patient die rather than do CPR and revive the patient, because when you are doing a CPR, there is no way you can predict that the person who will recover fully. I have had CPR done on me more than 17 years ago. I arrested on a cath lab table. I'm sitting in front of you. I'm giving you a lecture here. The point is, when the CPR is being done, if the cardiologist at that time had thought maybe he will go into a vegetative state, maybe he had some, if the cardiologist had some doubts in his mind at that time, I would not be here. The point is, these kind of judgments are not challenged by us, by our societies. In higher courts, we do not petition the government to correct these kind of statements which come in judgments, which create problems for us later. Another problem, you have given anesthesia, you are going in for an appendectomy, consent has been taken for appendectomy. While closing the abdomen after appendectomy, you find there is a mildly inflamed Meckel's diverticle. Now, this is not a medical emergency. And what does the law say? Samira Kohli judgment, Samira Kohli versus Dr. Prabha Manchanda judgment of 2008. It says very clearly, if you have given anesthesia and inside you find something which requires an additional procedure to be done, whether the additional procedure is going to cost more or second anesthesia is going to cost more or have more risk for the patient is not your concern. You have to let the patient come out of anesthesia, finish the surgery of that day, take a separate consent for removing the Meckel's diverticulum, and go in maybe a week later and remove that. This effect, in effect, is what the law wants. Whereas the medical practice, I mean, all of us have seen this on a routine basis. Umpteen times, a routine appendectomy used to be done while something else was being operated on, and this was never an issue. But today, there is a conflict between law and medical ethics. And my ethics tell me it is in the patient's interest that I do this. But since the law says I cannot do it, it creates a problem. Another thing, I know I can save the life of the patient by doing XYZ procedure, whether it is peripheral band ligation, whether it is whatever. But I do not do it deliberately because it is a high-risk procedure and I today want to avoid legal hassles. My experience 20 years ago for GI endoscopy may have been much, much less. But today you ask me to do the therapeutic procedures which I was routinely performing 20, 30 years ago, and I am no longer interested. I would refer them all to a higher institution, to a tertiary institution. This is again an issue where there is a conflict between my medical ethics and what I am seeing law do to me. Because if the problem occurs, I know if I do the procedure in time, it is in the patient's interest. But the court's view, what the court's view will be under the circumstances is something I am now concerned about. 20 years ago, we never used to have any fear in our mind. We did procedures which were not even described in those days. The fact remains, because of all these judgments which have come in, because of all these laws which have come in, we have started practicing defensive medicine, and this is against my medical ethics. Then is the issue that we know that we can save a person, but we don't do it because our sensibilities get offended. Our sensibilities do not get offended when 16,000 farmers commit suicide every year. They do not get affected when 12 million females are born in India every year and 1 million are either killed or allowed to die of neglect within first year of life. Our sensibilities do not get affected when 12,522 people across the country are still engaged in manual scavenging. Our sensibilities are unaffected when children are sold by parents to work in brothels. Why is paid donation of an organ illegal? Because it offends our sensibilities. But then we are not offended when there are thousands of beggars who are living on the pavement, when a father poisons his children and then commits suicide due to poverty, when there are brides who are bought and used by so many males in a particular state in India. Our sensibilities also do not get affected when we say ki 1,36,000 people die every year in India due to renal failure because they cannot afford a transplant or they do not have a donor. But we are doing only 7,500 transplants in a year in the country. After all, Iran has legalized paid transplantation. Why is it such an issue? It is an issue of medical ethics. I understand that. Again, provocative I am, and I am an activist, and I don't apologize for it. My question is sale or renting of other body parts or tissue legal? Here, blood, semen, human eggs for assisted reproduction, renting a surrogate mother, all this has been done in India. ICMR, in its guidelines, mentions about payments which is to be made to volunteers for expenses and compensation of work days lost. But some people clearly consider this as undue inducement. Even Western countries, solicitation for volunteers is done openly for research studies, and it is reasonable, legal, and ethically justified to motivate someone using monetary reward to participate in human research. So these are all ethical issues, but which are in conflict with law and may be difficult to resolve in such a short talk or lecture or a debate which may follow. If people were permitted to sell the kidney, what would be there? There would be no illegal trade, no exploitation, no middlemen. Checks and balances can be brought into place to safeguard interests of donor. Countless lives on both sides will be saved, potential recipient and potential donors, and no doctors will be arrested so that newspapers can sell based on the sensational headlines. Now comes the Medical Termination of Pregnancy Act, which says it is ethical to do an MTP up till 24 weeks. But we also know a 23-week-old fetus can survive with proper care. So the issue of medical ethics has forced us to think on many issues which we were not having earlier when law was not interfering so much in our medical practice. Forcing anesthetists to take up cases not fit for surgery. Is it ethical? We have God complex surgeons who throw tantrums in operation theaters against anesthetists and nurses. Is that ethical? Our dealing with our co-workers. This is something which is an issue, and this is rampant across the country in major institutions, otherwise also. We also know that being awake for 24 hours is equal to having blood alcohol content of 0.10%. But if doctors are working under influence of alcohol is unethical, then so is forcing them to work in sleep-deprived state. If I want to conduct a survey in any major tertiary institution in the country, what is the average working hours of doctors, junior doctors in the institution? The average answer is going to be around 80 to 90 hours a week. This is being very, very conservative, if it is not 110 hours a week. So why our ethics do not arise in this situation also when we are treating our juniors with what I call a mother-in-law complex. This is a mother-in-law syndrome. We did it. We never raised a voice. So they should also do it. And majority of the problems related to ethics in India today has come from the commercialization of medical education. I can speak a lot on this. I will just end it in this statement which I have made. If we go to the 2002 regulations which were concerned with ethics and professional conduct, in a hurry, because this is what is legal today, and the 2022 draft regulations, we are all sending our inputs, and we don't know what the final version is going to be. But in a month or so, in maybe a month or 2 months, the regulations of 2002 will cease to exist, and a new this thing will come. So, according to the regulations, we are supposed to uphold the dignity and honor of the profession, render service to humanity. Reward or financial gain should be a subordinate consideration for us. It is very clearly mentioned that a person obtaining qualification in any other system of medicine is not allowed to practice modern system of medicine in any form. But Maharashtra has permitted in 1992 all BMS doctors to practice modern scientific medicine. They have registered them in the state medical register. Haryana made this notification that Ayush doctors can practice. Similarly, there was an issue regarding homeopathic doctors being permitted modern scientific medicine. So all these regulations, which we say, this point, which is very clearly mentioned in these regulations, carries no meaning, because anything mentioned in these regulations are related only to doctors of modern scientific medicine. Anybody and everybody else can do anything. If I just resign from my registration of State Medical Council, I can practice in any way I want. There is hardly any repercussion. But as long as I'm registered in State Medical Council, I have to follow the ethical regulations which have been laid down for me and the conduct which has been told to me. The physician should practice methods of healing founded on scientific basis and should not associate professionally with anyone who violates the principle. We have to maintain our indoor patient records for 3 years. This has changed now. Clinical Establishment Act has mentioned very, very clearly that it is outdoor and indoor patient records, and we should be maintaining these in an electronic format. What the 2002 regulations had said was efforts shall be made to computerize medical records. That is, efforts shall be made. It was not mandatory. But now, gradually, things are moving towards a situation where the medical records will all have to be electronic. And similarly, use of generic names of drugs, it is again coming in the 2022 regulations, and we will all have to use that. A physician who is rendering service on behalf of the state shall refrain from anticipating or accepting any consideration. This is something that was there earlier, but then corruption cases have been filed against doctors in government service earlier also. We can refer a patient to somebody else, but in an emergency, you are supposed to treat the patient. Again, the issue of ethics comes in here. If I am an anesthetist and the problem is a foreign body in the eye, what is an anesthetist supposed to do? Mind you, most anesthetists work in institutions, but many anesthetists have clinics and pain clinics, and otherwise they run establishments where they do general practice kind of a situation. Let us put it another way. A senior nephrologist retired from PGIA is doing his practice, a consultancy, and a lady comes in for delivery. It's an emergency. Is he supposed to deliver her? Why do we put certain things in the law which will create conflict? We are not supposed to either aggravate or minimize the gravity of the patient's condition when we are counseling the patient. This is true across for doctors, for physicians, for surgeons, for anesthetists. A physician is free to choose whom he will serve. He should, however, respond to any request for assistance in emergency. We are forbidden from using unnecessary radiology laboratory investigations, but it is easy to say this when there are compensations of crores being awarded for not performing a particular investigation in appropriate time. Utmost punctuality should be observed by physicians. Case summary should be given to specialists who should communicate his opinion in writing to the attending physician. If you are referring a patient to somebody, the person should not directly be giving his opinion to the patient. He should be sending you a letter. But unfortunately, all these have remained on paper. They haven't translated into practice. This is true in Western countries, but not so much in India. Where it comes to my ethics with my co-workers, with my co-professionals, other doctors, we should render gratuitous service to all physicians and their immediate family dependents. This is something very easily stated here. Problem today is, I am a cardiologist. If my work is doing angioplasty, it is impossible today to do gratuitous angioplasty on even a close friend. So cost of medicine, cost of Medicare, cost of healthcare has become such that these things coming in law have become infructuous. In consultations, all due respect should be observed towards the physician in charge. Consultant should not criticize the referring physician. And physician occupying an official position, if he's coming to inspect something, he should not make statements which will reflect poorly on the consultant in charge. Duties towards paramedical professions. Physicians should disseminate advice on public health, play their part in enforcing laws of the community. Physicians should, when an epidemic occurs, a physician should not abandon his duty for fear of contracting the disease himself. Physicians should recognize and promote practice of paramedical services. Soliciting of patients directly or indirectly is unethical, but the word soliciting has not been defined. What exactly do you mean by soliciting is something which is unclear from the definitions given under these regulations. You should also not boast of your cases, printing a self-photograph. I mean, you can give advertisements. These are 6-7 situations where you are permitted to give an advertisement, but printing of self-photograph is unethical. It shall be unethical if benefits of any patents or copyrights are not made available in situations when it is in interest of the nation. Running an open shop is not permitted for a physician. Should not give or receive any gift, gratuity, commission, or bonus in consideration for return for referring, prescribing, or dispensing by a physician of secret remedies is unethical, and a physician shall not aid or abet torture or concealment of torture. Again, when you are dealing with the police, these regulations remain on paper. I think I'm overshooting my time. Should I cut short, ma'am?
Currently, you are within the time. Dr. Neeraj?
Yeah.
You have 5 to 7 more minutes to live.
Okay. When you are dealing with a pharmaceutical industry, do not take gifts, do not accept travel facilities, do not accept hotel accommodation, and do not accept cash. In research projects which are funded by pharmaceutical industry, you have to have due permission from the competent concerned authorities, clearance from ethics committees. It should fulfill all legal requirements. Source and amount of funding should be publicly disclosed. Proper care and facilities provided to human volunteers, and undue animal experimentations should not be done, or if necessary, they should be done in a humane way. An RMP should insert a clause in MOU that allows him to publish the results so that results can be used for public good and never compromise on his or her professional autonomy. You can work for pharmaceutical industries in advisory capacities as researchers or as treating doctors. You should not endorse any drug or product of any industry. Misconduct, there are many misconducts which have been listed. The first one actually covers everything because it says violation of any of the regulations. If you do not maintain records, if you do not display registration number, adultery, improper conduct, conviction by court of law, and this is not mentioned that adultery with patient, it is simply adultery. Sex determination tests, practitioner who has shown to have signed, given his name, under his name and authority, any certificate or notification which is not true. Prescribing steroids or psychotropic drugs when not needed. Selling Schedule H or L drugs and poisons in public except to his patient. Performing or enabling unqualified persons to perform an abortion or an illegal operation. Shall not issue certificates of proficiency in modern medicine. Should not contribute to the lay press articles which may result in advertising for himself. Cannot have an unusually large signboard in a court of law or in circumstances where serious identifiable, if the person is suicidal, yes, you need to disclose what you have learned during your consultation. Or if it is a notifiable disease, you have to disclose to public health authorities. Otherwise, confidentiality is a major issue. And if you violate that, you are liable to be punished. Should obtain in writing consent when you are to do any procedure. You should not use any tout or agents for procuring. You should not claim to be a specialist unless you have a special qualification in that branch. Informed consent of female patient and spouse as well as donor for artificial insemination should be there, and violation of existing ICMR guidelines in research shall also constitute a misconduct. Once a complaint is made, medical council can hold an inquiry, giving opportunity to the registered medical practitioner to be heard in person or by an advocate. This is violated by many state medical councils, but it is within law to take an advocate to defend yourself in state medical councils. They have to give a decision within 6 months. And if the state medical council does not decide within 6 months, National Medical Commission, the Indian Medical Council can take the case up on its own. Any person aggrieved by decision of state medical council has to appeal to MCI. Now, these are then the ICMR guidelines for research, but a part of them we have already covered, so I'll just skip through these. The issue of compensation if you do any harm in medical research is something for which you need to take an insurance today, which was not there earlier. And if you are doing animal studies, there are a number of acts related to that which you should see you are not violating. Physicians also frequently become targets of political repression and frank human rights violations. Doctors have been arrested on charges of conspiring to overthrow government in Bahrain because they treated injured demonstrators. Dr. Binayak Sains was one such incident which happened in India. He was an alumni of CMC Vellore and he was working in an area of need and in Chhattisgarh, and under Special Public Security Act and unlawful activities, just because the patients he was treating could be called Naxalites was the issue. In summary, medicine in India today is still the most ethical profession to be in. Doctor-patient relationship is definitely dwindling because of feeling of persecution among doctors in India, unrealistic expectations of a largely illiterate population, fueled by irresponsible media. Propaganda has been used to blame doctors for failures of successive governments. Doctors have failed as a group to get unfavorable and irrational laws amended and uncooperative law and order machinery. In earlier times, when the king's son used to go to school, he could not be beaten by the teacher. So there used to be another boy who used to accompany the prince to school. So when the teacher had to beat the prince, he actually beat the boy who used to accompany, and this was called a whipping boy. So doctors today, in my view, are the whipping boys of the society for everything which is going wrong in healthcare. Thank you so much. I am very sorry I have overshot.
Thank you, Dr. Neeraj. Thank you for an elaborative talk on ethics and differentiating between ethics and law, emphasizing on that. And my apologies in the beginning for technical issues, which I missed out just for a few seconds. And thank you, Dr. Jayashree ma'am, who overtook my role. Thank you very much. Before I open the question from the panelists here, I would request Arpita to let me know if there are any questions in the chat box from the delegates. Arpita? I think while she is replying this, I would like to ask one important question from Dr. Murali and then one from Dr. Neeraj. Okay, Dr. Murali, as we talk about, we all know the emphasis of positive attitude, and we need to keep this attitude ongoing. And in the current scenario of the stress, especially what we had gone through a tough time of 2 years of COVID, wherein a lot has changed, you would have also seen a lot of mental health issues amongst our residents, which is becoming like an epidemic. If I see the current scenario, Indian prevalence, 1 in every 5 normal population and 1 in every 3 healthcare worker in current scenario is either subclinically or clinically depressed.
I agree.
Okay. Where is it that we are going wrong? And we do know that we should be talking about, we should be keeping a positive attitude. What practically we can incorporate in our curriculum, in our day-to-day life to look into this issue?
Now, it's a very valid, I would say, not a question, but an observation, right? Now, what is happening across the world is what we are seeing here. Now, if you see the impact of social media that is actually having on our population, you will see that from 2010 to 2013, okay, there has been an increase in depression episodes and suicides among preteen girls across the Western world, US, UK. Now, the owners of the big companies of social media say that they're doing, everything for the good of the public, as you might have seen, many people speaking. But definitely, the source of problem is much deep-rooted than we can actually correct or we can observe. Now, as you said rightly, a lot of people went through depression. A lot of people went through major issues in the last 2 years, and I've had to counsel many of my juniors as well. Now, I feel the solution is in a very simple statement that if there is a good purpose in life, then people will not look at the other things to entertain them. So, as a quote goes, if somebody has got a good purpose, he is living a happy life every day. But if he doesn't have one, he is actually looking at pleasures to entertain him, which is nothing but a dead end. So I think we have a community wherein a lot of youngsters, especially, have had, I would not call it easy life, but definitely not had a struggle. Now, I might be wrong in this because many of the youngsters might be going through a lot of struggle. I'm sorry for that, but majority of the population is, say, example now, if I see, eminent people here, Dr. Jayashree, Dr. Murali, their earlier days during training was much tougher than mine. And probably mine was more tougher than what people go through now. So I think that is one aspect of it. Second thing I feel is discipline and spirituality. Now, what discipline does in anybody's life is it brings in a sense of self-respect Now, if I keep an alarm at 6 o'clock and I wake up and I go for a run or whatever it is, I start respecting myself. So there is a respect that develops towards oneself. And I think that is important to take you through difficult times, because you're not looking at others to give you compliments. You're not looking at others to say that you're good, or you're not looking on, wanting those Facebook likes. You know that you are good enough. And if that comes in, I'm sure a lot of these issues will get solved. Second thing is, I believe in spirituality. I'm not talking about religion per se, but they connect with the inner self. So I would call that as spirituality. And meditation definitely makes a huge difference, because it keeps you in the present moment. And most of the problems that come with anxiety, fear, depression are all related to the mind traveling into the past or the future. So I think staying mindful of the present moment, and that I think is a very big issue amongst the junior doctors presently, staying in the moment, being aware of what's happening, reacting to crisis. All this stems from being in the present moment. So I think meditation does a lot to be in the present moment, which again takes the mind away from future and worrying about things, or thinking about the past and feeling depressed. So that is one. The third thing I feel very important is a good group of friends. Now, with increased social media, people are not meeting in person, and that is one thing which happened in the last 2 years. So meeting in person, sharing issues that they're going through, having good, strong friendships and a good family, I think goes a long way in helping most of these problems. I hope I've answered all your questions.
Thank you, Dr. Murali. You have beautifully answered. These are the basic essential components of the life, which is not just professionally important, but important for the personal life as well as for having the personal relationship.
Yes.
As you correctly mentioned, that meeting physically really releases a lot of endorphins. So yes, we had come through a tough time. Another thing which I have noticed is that we are seeing, yes, yoga and meditation should be probably, the spirituality should be the part of our teaching right from the schooling days, rather than, just inculcating in the undergrad or the postgrad. Should be from the beginning. That would, as the most of the Japanese and the Bhutanese with high happy index factors, they do it. In the current cutthroat competition, we are seeing lots of high achievers. And in that high achieving concept, they tend to lose the differentiation between value of a good relationship versus achieving something. So the cost is there. Yes. So thank you very much. You've well answered and beautifully said. As I said, that we'll definitely like to, announce here, Dr. Murali has been a extremely positive person with a positive attitude. And as he mentioned, keeping the positive people around you keeps your attitude also positive. Thank you.
No, I know people here and all the panelists, I'm sure are all, I've interacted with most of you, and, there is a lot of things to learn from each one of you, which we have all done. So thanks a lot. Thank you.
Dr. Neeraj, before I hand over this to other panelists, as you also mentioned during the talk, yes, being anesthesiologists, most of us and many of us are nowadays coming up with the chronic pain practices. And you talked about a lot of ethics related to the anesthesiology, the CPR, euthanasia, donation. Yes, for the delegates here, they are the youngsters who might be taking up a pain practice as their career. Few questions. One is that to what limit is it that they always wonder to what limit we can advertise ourselves? You did talk about in a one slide hurriedly, but this is one thing which is confusing them. That because most of the anesthesiologists do not go into direct touch with the patient and probably may not be advertising, or they would have a good group practice, which goes through the word of mouth. But when you start a pain practice, you need to be opening up a clinic. So to what they're so confused, how much can they advertise about? for this?
I'll answer this in two ways. One, what I think should be there. Two, what is the existent law? The existent law is that you can advertise at the start of your practice. You can advertise telling the cost of various procedures in your center. You can advertise that I am going on leave for one day on Sunday, and next day, Monday, you can again advertise saying I have rejoined duty. You try to understand, you have to use the legal loopholes if you wish to advertise. It cannot be half-page advertisements with photographs of patients and photographs of doctor. All that cannot be there. But you can advertise. Now comes to what I think should be there. We have been very, very selfish as seniors that we have not opened professional space for our juniors. We say patients should be gathered or patients should be sought by mouth-to-mouth referral, by one patient referring you another patient. But I have finished my MD anesthesia, I have done my fellowship in pain management, and I have started practice today. I do not have any patient. Who's going to refer the patient to me? So my point is, advertising actually should be permissible. It should be ethical advertising, which should be permissible. I had written an article regarding this in Journal of Cutaneous and Cosmetic Surgery. I'm forgetting the full name. The point there was not only because like for pain management you are talking here, in their case, it is all these treatments where lasers are used and hair transplant is done, all this kind of work, which is also done by non-doctors, non-specialists, people who are not even medical people. So effectively, when you are competing against them and their full-page advertisements, you need a free hand, you need somebody to advertise himself. But unfortunately, this is not the law today. So one part. Second thing is, I will dispute partly with what Dr. Murali has said. Yes, we have seen tough times. Yes, our seniors probably had tougher training protocols. But my mother-in-law asked me to bring dowry. That is why I'll ask my daughter-in-law to bring dowry is no explanation. Do a comparative study. What is the quantification of the attitude of a resident who joins PGI anesthesia department? And what is the quantified attitude of the resident once he leaves the anesthesia department? And tell me the difference there. Under RTI, we are collecting information from 54 government medical colleges, including PGI, where we have asked them, you tell us how many residents have joined, worked for 6 months in a particular specialty or super specialty, and left after that. How many have committed suicide? How many? These are issues which we are hiding under the carpet. We cannot agree to have this thing continue indefinitely. Whatever the training programs we had in the past, I had a tough training program. I am proud to say we used to work 72 hours nonstop. But if I tell that to my daughter or my son today, he says, you people were stupid. Because if you worked 72 hours, obviously you were making mistakes. It is not possible not to make mistakes if you have been working 72 hours continuously. And yes, I can remember the time when LP had to be done in Ward 5 and we used to do in bed number 1, Ward 6. These are issues. We have seen so many instances during our trainings, but that was the time when Consumer Protection Act was not there. That was the time when all this accountability was not a major issue. Today, if you want residents not to make mistakes, you have to provide them a safe work environment, a phase where they feel secure, which is not what is happening. Violence, how many incidents of violence did we have when we were doing our post-graduation? Hardly any. What is the situation today? Any government medical college today, you go to an emergency, daily there is an incident of violence, daily. Correct me if I'm wrong.
Dr. Neeraj, I think Dr. Murali will definitely speak, but Dr. Murali had made it very clear that he didn't mean that the residents or the generation currently is facing less of issues. Probably what we faced were different, and definitely every generation faces lots of challenges, and the current generation is facing a different challenge. And we were probably, I would say that we were probably less stressed, and the incidence of subclinical or the mental health issues were lesser in our generation. So definitely the younger generation is facing a challenge, and this is what he made very clear, that he didn't mean to say that the younger generation either is born with a silver spoon. No, they have different challenges. I think Dr. Murali, can you just speak?
Yeah. No. As you said, what they're having is completely a different thing, especially with social media. Now
Yes.
they're subjected to so many different things. On Facebook, nobody puts a photo of them having an illness or having a bad time. It's always the good things that get projected, and this kind of a pressure that they're having is what I said is different. And also what we went through as training programs, as Dr. Neeraj was mentioning, things were different then. As I said, the violence was less, and various things were not there during those times. And of course, we didn't have the social media also to complicate the issues. Having worked in the UK, where we were working only 48 hours because of the European Working Time Directives, and having worked in India, where, as Dr. Neeraj was mentioning, we were doing 72 hours, the practices were different. But still, having said that, the North American residency programs are still strenuous. And therefore, I think that just working hard was not the only thing, but I think the other things which are adding to this, especially the mental stress, is quite a lot, and they need to have the other avenues to kind of absorb the shocks that they actually go through on a daily basis.
So it is external gratification, external pressure. Somebody should, put a stamp on me for my happiness, is one thing which is coming up, especially with the upcoming social media. That is one thing, rather than having inner peace or inner happiness. And thank you, Dr. Neeraj, for highlighting what I asked. Ma'am, Dr. Jayashree Sood, ma'am, and Dr. Sanish, any other question? I am still asking. Arpita, you are there. Do we have any question from the delegates?
No, ma'am, no.
Okay.
Questions are there. They are just sending congratulations and good session, but no questions from them.
Okay, so compliments and comments are there.
Yes, I'm not surprised because the lectures were so good. I just want to add a little. Yes, I've been hearing all this, and there was such valid discussion, and the lectures were so good. But definitely, when we are talking about the students of this generation, you will agree with me, they are more ambitious in the sense. You remember when we were, of course, I'm the senior most, and we never even thought of a car at that time. It was so difficult. But nowadays, you will see that the first year DNB or the second year, they all have cars. And one student has a car, so the other friend also wants. So that's one part of it. But definitely, it's, of course, the counseling, the HOD's role, the senior's role plays a lot of this thing. It plays a very important role in counseling the students, of course, the teamwork, and they have to have a time where they can have socialize and have some, probably once a month, some little get together. So that's there. So the balance has to be created. And that's one thing that I just wanted to comment.
Excuse me, shall I make a small point? I think the present generation, many people are thinking about a medical profession to make a good living. Okay, so what I am trying to bring out is, should there be an aptitude test before selecting somebody for the medical course, just on the merit of the so-called entrance test or any qualifying exams? Is there any possibility of an aptitude test? Because medical profession is a service as well. So you cannot imagine getting into this profession just to make money or fame. Yes, sir, please.
May I answer this? Now, the thing is, when we talk of aptitude, we have permitted medical education to move from government sector medical education to trusts, which were non-profit trusts, to profit-making organizations providing medical education. 50–55% of your medical colleges today are business houses. They are selling MBBS degree, they are selling postgraduate degree, they are selling super specialty degree. When we talk of aptitude, it is very, very difficult. You tell me this thing, the entrance exam, the NEET which was brought in, we wanted quality, so we had 50% marks as a cutoff. What happened? People who could clear the exam did not have money to pay for the private medical college education. So what was done? We have reduced the 50% as a cutoff to 50th percentile, which now works to 18% marks in your entrance exam for a general category student. When this is what we are talking about academics, for aptitude and other things, I'm sorry to say, with the kind of scenario which medical education has been brought to, I mean, this first will have to be checked before we force people to pay 3 crores for a DM, but pass an aptitude test to have an aptitude for medicine. This is a contradictory to whatever we would ideally want.
Dr. Murali?
Yes, I'm waiting. Sir, finish. Dr. Sanish, just wanted to kind of speak about the same thing. Now, having, I mentioned in my talk that majority of the doctors, especially who have come through merit, have been in the 5th top percentile of their class. So in school, in the top 5th percentile, so they got into a good college, top 5th percentile, they got into a postgraduate seat. So now you have a class of people who have been actually literally the cream of the society. Now, why they go through all these issues, why they feel the lack of self-worth is because of the comparison that they have with other professions. And especially in the last 2 decades with an IT boom that India has seen, we have seen a lot of youngsters with a good amount of money. And this comparison has led to a lot of uncomfortable feelings and the need, as Dr. Jayashree ma'am was saying, need to grow quickly, need to get this car, build a house and everything. But if they just apply a simple rule of compounding, that yes, I need to save a little bit, and at one point I will be better off than the other people around, I think that will go a long way. And I think here, as Dr. Neeraj was saying, the amount that has been invested by many students in their education, they feel that they need to retrieve it back. So there's another pressure in that context where they want to earn and they want to kind of repay those loans probably. I've had many juniors who needed money only to repay the loans. So there's a lot of other issues. It's not just a very straight thing. And on another note, I would just like to remind Jayashree ma'am that I think 6-7 years ago, when I was moderating a panel on work-life balance, I'd asked her what is her attitude, which makes her so happy, always cheerful in life. And she said, every day when I go back home, I behave like a houseman with my, at home. I'm not a head of the department, or, I don't think I'm a big professor. And the same goes with my husband. And both of us are so cheerful, as if it's like the, first year of our internship. So that is the secret of happiness at home. And that attitude is what we should carry to home. Am I right, ma'am? I think I'm quoting you from past probably 5 or 6 years ago.
I must say you have a very good memory, and I can just add on that now at home I have my grandchildren. So once I come home, it's a different scenario altogether. Yes, it's so true. It's so true to have a balanced work-life balance should be there.
Thanks, ma'am. Thank you.
Thank you, ma'am. Ma'am, we have already overshooted nearly 7 minutes. I still feel like talking right now, answering something to Dr. Sanish, but I think we can stop here. Only thing is, Sanish, I would like to add is agreed that our profession is a profession for services, but it is money which revolves the word going. So we cannot say that the monetary aspect is to be kept at the lowest expectations. No, we need to have some standard of living. We need to be, as Dr. Murali rightly said, when we see our peers, and there is always a level which is required, especially after putting so much of effort. Yes, that hunger for money should not be there, agreed. But then money is still an important aspect, an important part of our living.
I think
About the aptitude test,
managements also should,
yeah,
corporate managements also should support it.
No, Dr.
Yes.
Sanesh and Dr. Babita, one other thing. We have been always taught with whatever education we've been having on how to earn money, but we've never been taught how to manage money. But now
yes.
there is an increasing awareness amongst doctors on how to manage their own money. So I think in the future, probably in the next 10 years or so, we will see much more savvy, tech savvy, financially savvy doctors coming out who will have probably a better work-life balance and also serve the community.
Thank you.
So with this, ma'am, I would like to end and really thank the wonderful renowned speakers, eminent speakers. The both of them have spoken so well and excellently covered the topic. Thank you very much.
Thank you, Dr. Babita. Thank you.
I
Thank you.
totally agree with you, Babita. Both Dr. Murali's and Dr. Neeraj's talks have been so interesting and so, they were all facts, of course, but so practical in the sense we see them in our daily lives every day. And it was a real learning experience for all of us. And the discussion can, of course, go on and on, but I think we'll have to say goodbye. Thank you very much. And thanks, Babita, for the moderation. As usual, it's always very dynamic. Thank you very much. And thanks, Dr. Murali. Thanks,
Thank you,
Dr.
ma'am.
Neeraj. And we are all looking forward to next Wednesday. Dr. Sanesh, thanks a lot for working so hard for it. And it will be our 100th webinar and it's really going to be good. So looking forward to next Wednesday, the 15th, to meet all of you. Good night. Thank you
Good
very
night.
much.
Thank
Good night.
you. Good night. Thank you.
Bye-bye. Bye.